Aloha everyone, and thank you for joining the COVID-19 Public Health Action Webinar, the Delta Variant's Influence in Hawaii and How We Can Respond. My name is Makamai Namahoe, and I am the Public Health Programs Associate. Before we get started, there are some Zoom housekeeping to go over. Next slide. For all questions, please utilize the chat box or question and answers box located at the bottom of your screen. No continuing education credits will be provided during this webinar series, and all webinars will be recorded and available on the Hawaii Public Health Training Hui's YouTube channel. Without further ado, I would like to introduce you to our presenters for today. Our first speaker is Dr. Janet Berraman, who is originally from California and trained as a pediatrician at UCSF. She worked as a general pediatrician in American Samoa for 4 years, and in 1992 was one of the first pediatricians to join Waianae Coast Comprehensive Health Center on Oahu, where she practiced until 2003. In 2003, Dr. Biermann returned to California, where she completed a master's of public health at UC Berkeley. She served as the city of Berkeley's health officer for 10 years. Returning to Hawaii as a Kauai District Health Officer in 2006 allowed Dr. Biermann to combine her rural Pacific Island primary care experience with the public health expertise she gained in California. Excuse me. Our second presenter is Paige Huckathorn Choi, who is a Senior Director for Government Affairs at the Healthcare Association of Hawaii, which represents more than 170 healthcare organizations, including acute care hospitals, nursing facilities, assisted living facilities, home health agencies, and hospice agencies. In her role, she helps to lead advocacy efforts at the state and federal level to support healthcare organizations and ensure access to high quality care for residents in Hawaii. Prior to joining her organization, Paige worked at the Queen's Health System as a legislative analyst in Honolulu. She also worked on healthcare policy issues as a legislative aide in the US Senate in Washington, DC. And our third presenter is Dr. Melinda Ashton, who is the Executive Vice President and Chief Quality Officer at Hawaii Pacific Health. In this role, she oversees all of the activities of the Patient Safety and Quality Services departments at each of the HPH hospitals and is also responsible for system-wide quality improvement initiatives. Dr. Ashton graduated from the John A. Burns School of Medicine and completed a pediatrics residency at Kapi'olani Medical Center for Women and Children in Honolulu. Board certified in pediatrics, she is also a clinical professor of pediatrics at the John A. Burns School of Medicine. So I'd like to hand it over to our first speaker, Dr. Janet Biermann.
Good afternoon, everybody. Thank you very much for the introduction and for your interest in being here today. I'm going to dive right in and talk a little bit fast because, as usual, I have more to say than my allotted time. It's a new game in COVID-19 over the last several weeks for us here in Hawaii, and that's been spreading around the world from India to the mainland to here. And that's what I'm going to focus on today. Sorry. So this is a quick overview of what I'm going to talk about. I'm going to talk about where we are now, about how Delta variant causes a difference, the difference that the vaccine makes, the ways our community are different than they were a year ago, and a little note about health equity. So where are we now? This is the epidemiologic curve for COVID-19 in our state, going all the way back to March of last year. So what you can see here is that where we sit now, we have not only the highest average daily number of case counts, but we have a steeper and more sustained rise in that rate than we've ever had before. So the things that we thought were surges in the past pale by comparison to the numbers that we have today. And I think it's important to understand where we sit nationwide. So in this instance, Hawaii is a red state. And if misery loves company, we're in good company, because you can see that almost every state in the country is also red by the CDC standards of high transmission rates. On the right here, we have a list of every state in the country and territory. This is from yesterday, giving the case rate on a population basis and ranking them in order. A few days ago, we were 7th in the country. Yesterday, we had dropped down to 13th, which was good. But in the past, we had always been way down at the bottom of this list. And this is definitely a list in which we don't want to be a member of the top 10. So if we're going down, that's good, but we're certainly not out of the woods. One of the things that is a lot in the media and the public discussion is what's the impact of travel? And is this because of tourism and because of the opening up of tourism? And while it is certainly true that new viruses come into our community as a result of someone coming here or some people coming here with those viruses, this graph, which is on the Department of Health's website, and you can look at it daily and you can sort it by county and by time. On this graph, all of the red bars are cases that were acquired as a result of community transmission here. The blue are cases that are related to travel. And within those, the light blue are our own residents who have traveled and brought disease here. And the very dark blue, of which you can see almost nothing, are the visitors who are bringing disease here. So I would just say that while travel is a contributing factor, clearly community spread is the dominant factor in the disease transmission that we're seeing now. So the first game changer, the first reason we have a new game is the Delta variant. And the most important questions I think that people are asking about the Delta variant early on was, is it more transmissible? And of course, the answer to that is a resounding yes. And that is really the root of the problem with Delta right now. We would also like to know if it's more virulent, meaning does it make people sicker? Is it more likely to put people in the hospital or to have a serious or even fatal outcome? And it's a surprisingly complicated question to answer, and we really don't know the answer to that yet. It certainly doesn't seem to be overwhelmingly more virulent, but whether it may be a little bit is really remains an open question. Because I think pictures are worth 1,000 words, I just wanted to share this image of how this disease is more transmissible. So we've heard a lot about the R0, which is a measure of the number of people that on average, someone with the virus will infect with the virus in turn. So the original strain and the early strains, one sick person who's in blue in this graph was likely to infect about 2 or maybe 3 other individuals. But with the Delta variant, one sick individual is more likely to infect on the order of 5 to 8 individuals. So 2 or more times as many people will get sick from every person who's sick. And in turn, each of those people will then infect that many more people rather than the 2 or 3 that they were infecting earlier. And that really is what brings about the exponential rate of growth that we're seeing. And as was reported in the news, this is about the level of transmissibility as chickenpox. It's more easily spread than smallpox, but less easily spread than things like measles and mumps, which we're familiar with. The second way in which the game has changed from a year ago is that we have vaccines now. And what we know about our vaccines is that they are extremely effective in reducing severe disease and hospitalization and death. And it's important to know that all of the vaccines are effective in doing that for all of the variants, including the Delta variant. So as we think about this surge in cases and the exponential growth in cases, it's really important to keep in mind that at some level, if the bottom line is that we can save lives, that's a good bottom line. I certainly can endorse that. So we know that the vaccines do this and we can have confidence in that, and there's good evidence of that. What we have learned, especially in light of the Delta variant, is that with the Delta variant, the vaccines are less effective in completely reducing any infection. We knew they wouldn't be 100%. No vaccines are 100% effective, but they're less effective in reducing infection, meaning somebody has mild disease or asymptomatic disease, but nevertheless is infected with the virus. And even more concerningly, those people who are vaccinated and infected can transmit the virus. They have very high levels of virus in their nasal mucosa and secretions. So that transmission slide that I showed you a minute ago still applies to vaccinated people who have become infected. And what that means is that the vaccines are not a substitute for all the other kinds of precautions that we've been using to prevent disease spread. So the third game changer is not maybe as dramatic, but I think the impact is equally important for us to remember. And it's in what are the changes in our community? If you think about all of us who are paying attention to this now and working on this now, and everyone who lives here, compared with where we were a year ago, we certainly know a lot more. We know more about the virus, we know more about how to respond to it and control it, and we know a lot more about medically managing it and treating it. So those things are all positives. We also have more experience as a community. Masks are no longer a novelty. You know, putting on your mask when you go out, making sure you have it with you. We've grown accustomed to that. We may not like it, but we know how to do it. The same with living under restrictions to our activities. We have experience with imposing those, with implementing them and enforcing them, and in living under them. Again, we may not like it, but we've done it before. We sort of know the routine and know the drill. We've had a lot more experience using our emergency response systems to respond to a pandemic. So this is bringing together the tools that we normally use to respond to a hurricane or a tsunami threat or a volcanic eruption. Using them for a pandemic is a little bit different, if nothing else, because it goes on for so much longer. And part of that experience is that we also have more experience collaborating, many of us with partners that we may not have had very close and prolonged collaboration with in the past. So those are positives also. But on the other side, we have a lot more fatigue now than we had a year ago. We may not have quite as much alarm or concern, but everybody who's been working on this is tired. The public health responders, the healthcare workers, the emergency responders, our elected officials, our residents, everybody is tired. And as I was writing this, I put down even visitors. You know, one of the reasons we have so much tourism is that the visitors are really tired of COVID and they're coming here for a break. So that fatigue has an impact on our ability to use our knowledge and use our experience effectively to continue to respond as the game has changed. So the new game where are we in this new game? And I really shouldn't be using sports analogies because I don't even know what game I'm talking about. I'm talking about the COVID game. So in some ways, there's a big advantage to COVID right now. The transmissibility of the Delta variant, as we talked about, is an enormous advantage to this virus. That makes it much easier for the virus to evade all of the kinds of protections that we're putting in place. Although we've done really well with our vaccination, we still have 40% of our population is unvaccinated. Many of those are young people who are too young to be vaccinated, and others are people who've chosen not to be vaccinated yet. And then our fatigue, as I said, contributes to giving an advantage to the virus over all of us who are trying to control it. But there are also some advantages on the disease control side. As I said, vaccinations are probably our biggest advantage. We're doing really well, and we have particularly done well in vaccinating those who are 65 and older. And those are the people who were most likely to have severe disease, hospitalization, and death as a result of infection. So it's a good sign that we are well above 90% in having fully vaccinated that population. We are better able to manage the disease. We have monoclonal antibody treatment. We have better understanding of how to provide respiratory support. And we have experience in all of the things that I mentioned before, including in contact tracing and case investigation and isolation and quarantine and all of those things. But on balance, you know, this game is still being played. We don't know who's going to win. And right now, we have fewer susceptible people because of having vaccinated people. But we're seeing even more transmission than we've seen before. So those very high case rates are in spite of the fact that most of us are vaccinated, and among those vaccinated people, they are unlikely to be infected, although they still can be, but they're a small contributing factor. So right now, looking at our curve with that unrelenting exponential rise, I think we have to say that transmission is winning and that the advantage to COVID is dominating. What we don't know is what will be, and are just beginning to get an inkling of, and I think Dr. Ashton and Paige will talk about this, is what the impact on hospitalizations and subsequently severe disease and death will be. We hope that even though we have these very high case counts, we won't see a severe impact in terms of mortality. And the reason to hope that is because of the high vaccination rate, especially among our older residents. I did want to comment about health equity because I don't think anybody from public health should make a presentation without considering this fact. So we know that we have big health disparities by race and ethnicity in our state in terms of chronic disease, in terms of life expectancy, and in terms of access to care. And vaccination is no exception to that. So the vaccination rates are lower among all of the populations and sectors of our community that also suffer from all of the other health disparities. And those things compound each other so that as we go forward and we can be confident that we have vaccinated our very vulnerable to severe disease population over 65, we also know that there are populations who are not in that age demographic, or maybe who have high rates of chronic disease and issues accessing care and are not vaccinated, and therefore will be susceptible to all the kinds of severe disease impacts that we see in unvaccinated populations. So there's a lot of attention in the healthcare sector and in the health department and in the community to getting vaccination to and improving access to all of these populations, but the health disparities persist, and I think it's likely that we will see them continue to play out in this pandemic. Dr. Char gave a press conference last Friday, at which I thought she was very powerful. And if anybody else is a Lee Cataluna fan, you may have read her article about it a few days ago. So I've paraphrased from both of those. And this is my concluding message, that our vaccines are a really, really powerful tool, but they're not a free pass. There's no silver bullet. No one thing in itself is going to get us out of this. As I said, they protect us from severe disease and death, but they don't protect us from mild disease and disease transmission. I don't think I need to reiterate it, but Delta is running rampant in Hawaii, and it's likely, if it hasn't already, to impact each of us in our households at a personal level, either directly or indirectly. So every single person in our state needs to have a plan for how they will isolate or quarantine either one or two members of their household or their whole household. And finally, to end on a little bit more positive note, we have really effective tools and we need to use them. And those effective tools that we know how to use are wearing masks, avoiding crowds, including all of the crowding that's associated with travel if it's not essential, staying home when we're sick, getting tested when we're sick so that we know whether or not it's COVID, and of course, if we haven't already, getting vaccinated. That's my last slide. Thank you very much.
Great, thank you, Dr. Biermann. That was awesome. Our next presenter will be Paige Huckathorn Choi, and she's going to give us an update on the hospitalizations.
Thank you, Makamai, and thank you to the HIPHI team for helping me with my slides today. So again, I'm Paige Huckathorn Choi. I'm the Senior Director of Government Affairs at the Healthcare Association of Hawaii, and we represent a wide variety, wide continuum of healthcare providers in the state. And we do represent the hospitals, but also the nursing homes, home health, hospice, as was noted in the introduction. So in today's presentation, I do want to focus on a lot of the situation in the hospitals. I'll talk a little bit about some of the vaccination efforts in our nursing facilities, And I will provide some overview of some of the proposals that we're hearing in response to this surge. So if we could go to the next slide. I really wanted to say I appreciate Dr. Biermann that you provided a great overview and what we've learned, what we can still do. And I really appreciated the quotes that you provided, the advice that you provided from Director Char, from Dr. Char. I think one of the big things that we took away from that as a hospital community is that we are on fire. What we're hearing from our hospital members is that staffing is stretched. We are running out of the ability to place patients quickly. There are issues sometimes with patients coming in with non-COVID related issues, not just for our hospitals, but also sometimes urgent care. We're hearing more that because there's such a strain on the system, getting routine care or getting care for something that is an emergency or an urgent situation is increasingly becoming more difficult. And I think many of you on this webinar, you're very engaged. You've seen all the news. You've seen the headlines about the ICUs filling on the Big Island here at Queens. You guys are aware of that. And I wanted to share a set of graphs. I really wanted to do something visual because I think everyone on this call understands where we are based on just trying to be engaged. But really, showing, similar to Dr. Biermann, how precipitous the rise in hospitalizations has been statewide. I want to note here two really, really important things. For a long time, we were really getting up to where our peak hospitalization rate was in our surge last year, at this time last year. And that peak number that we had in the hospital was 318 or 318. And today I found out we are at 319. We have broken the record that we set last year for the number of hospitalization patients today. So we have more patients in the hospital today than we did at any point during our surge last year. And I think that's just an important fact that we need to know. And I also just want to note that we do have that steep incline for the number of hospitalized patients. I think Dr. Berraman, some of your graphs showed that it was a little bit more of kind of a soft curve. It doesn't mean that at the time those increasing numbers weren't very concerning, but I think you can see on the right-hand side just how steep that curve is and how exponential that is, to borrow one of Dr. Berramann's words. I just want to make another point though here too is, we've clearly surpassed the record number of cases that we had last year, but we know based on what we've been seeing that 4.5% of all of these cases turn into hospitalizations. I think that's a little bit of a lower rate than you're seeing in some states, but with the continuing high numbers of cases, even if it's not quite as shocking as a 700 or a 600 or a 500, with those case numbers, when we've already hit those records and we're already at capacity, it's very concerning looking at our entire system and making sure that we're able to respond to that. So if you could go to the next slide. And these all, I won't speak too much of these because I don't want to, I do want to leave enough time for questions, but you can see that the rate that large precipitation in rise is the same for the total number of COVID patients in-house per day. And then if you could go to the next slide, or in the ICU, and this is the admissions. And I think that this is the chart that really I have been looking at a lot. If you look at the number of admissions, we are admitting COVID patients in much higher numbers. It's not even a rate, it's just in much higher numbers than we ever did in the surge last year. So people are coming in every day. It's harkening back to what I said previously, which was just that, I think, even if you see the case counts going down, they're still at such a high rate that we're seeing a lot of people come into the hospital. And I think a lot of folks have seen these numbers that it's 90 to 95% of those are unvaccinated. So even though we are doing really well in our vaccination, and Dr. Berraman, is completely right in that, and our hospitals are really involved in that effort, that even then, it's not just the case counts, it's not just the rate, we are seeing high numbers of patients coming into our hospitals every day. So if you could go to the next slide. I'm pulling out Honolulu County here in terms of the data. I understand that a lot is happening on the neighbor islands. We're very concerned about our neighbor islands. There's been a lot in the news recently about Kona in particular, but also Hilo having to bring in staff a little bit earlier to manage their situation. Their ICUs have been full for longer. But I just wanted to bring in Honolulu because there was a report recently by HIPHI that the rate of transmission in Honolulu County is actually 20% higher than what they had initially thought it had been from August 5th. So they had modeled out a rate of transmission. It is higher than even they anticipated. And so, of course, that just sets off some alarm bells for us to think, okay, this is happening a lot more quickly. And it goes back to what Dr. Biermann was talking about in that this virus, this variation of the virus, is really just taking every opportunity it can to find a new path to infection. So it's very interesting. So we do see what's happening on the neighbor islands, but I think that we should still also be very focused on Honolulu County, making sure that we're looking at those transmission rates, and then of course just looking at how it is progressing in terms of our COVID patients in hospitals. So if you could go to the next slide, I won't add more points to this slide, but again, just showing the high rates and quick ascension in the COVID patients in ICU beds. And to the next slide, total COVID admissions, and you can see high numbers coming into our Honolulu area hospitals. So to the next slide, I also just wanted to put this in, this is a larger issue and I don't, want to take all the responsibility of DOH, but I did want to provide some data that we have from testing from some of the labs with our members. And I just want to note that on the red, you can see that not only are our case numbers going up so much, but the test positivity is going up. And that's, I think, another big concern is as much as you have the test positivity going up, that could be a very, very concerning statistic that we use, in part because, when you do have more tests and you have it going up, I think it's an indication that there might be more spread in the community than we're catching. So to the next slide. I do want to share some somewhat good news, although some things are changing, and I can speak to that a little bit later. But one of the good areas is that Hawaii nursing homes have done an incredible job of keeping both residents and patients safe. Of course, there were incidents. Whenever you have high community spread, you are going to have the virus introduced into nursing facilities, but they've worked very hard to try and keep patients and residents as safe as possible. And I think a testament to that culture and that mission is that Hawaii actually has the highest nursing home staff vaccination rate at just over 88% among all 50 US states. It's second only behind Puerto Rico. And this has been really important in terms of managing outbreaks. So we are having outbreaks at a lot of our nursing facilities. And as Dr. Biermann said, the vaccines are very effective at keeping people out of the hospital, keeping people from dying, especially for these very vulnerable populations. That doesn't mean that it's not still a big burden for these nursing facilities, and it doesn't mean that it doesn't automatically cause a lot of activity at these nursing facilities to make sure that they're keeping all of the patients safe if they do have a positive case. But it has been very effective in protecting the most vulnerable. And so if you could go to the next slide. You'll also see that we do have a very high rate of vaccination for our residents, again, protecting the most vulnerable. We still have a high rate. I think that, we're a little bit further behind. We're still in the top 12, we're 11. So it's a testament that other states, other residents are taking this very seriously, but we have a very high rate of vaccination for these residents, and that is providing some protection. Again, it doesn't mean that everything is hunky-dory. There's a lot that you have to do when there is a positive case at these nursing facilities, but it is achieving a lot more protection than I think we were seeing, especially on the mainland, when residents were totally unprotected with no vaccines. Now, interestingly, maybe a couple hours before this webinar, there was an announcement from the Biden administration that's been appearing on various news sites that there likely will be a mandatory vaccination for all workers in any nursing home. We don't have a lot of details on that, but that was announced just a couple of hours ago. So as we get more information, we'll be able to understand better what that looks like, what that mandate looks like. And then I think the question is, is it just starting with nursing homes? Could it go beyond that? So those are questions that we have unanswered, but it was an interesting development just a couple of hours before we joined on this webinar. So if you could go to the next slide. So that's kind of where we are. It's a very perilous situation. Staffing remains by far the biggest issue. There was a press release issued earlier today that in a partnership between HAH, HIPHI, and the Department of Health, we were able to secure approximately $45 million in federal FEMA funding to bring in around 550 staff. That's mainly nurses, but there's also respiratory therapists, medical technicians, other healthcare professionals who are coming in to help alleviate the state. There were 36 professionals that I believe started yesterday at Kona Community Hospital. They really needed the relief. I think it was 33 nurses and 3 respiratory therapists have started there starting yesterday to help alleviate that staffing shortage that they've been having. Just for context, last year at this time when we had a surge, we used around $17 billion. So much less than the amount that FEMA is providing. That was $17 million in CARES Act funding. And we brought in about 150 to 200 travelers. They came in different waves, but it was about 150 travelers at any time. And so that's really notable that we're bringing in nearly 4 times as many staff as we brought in last year to serve more hospitals. So we're actually serving, I believe, 18 hospitals this time versus 10 hospitals. Only 10 hospitals really needed that surge staffing. And this is really important because it's not just that you need staff to help fill in where there's burnout. You know, Dr. Biermann talked about burnout, but we have the beds available, but we need staff to be able to actually take care of patients in those beds. That's always been the biggest critical path for us. The biggest barrier is having enough staff to actually serve the beds that are available. We don't necessarily need to be popping up tents or bringing in, you know, a big ship. We just need boots on the ground to be able to staff the beds that we do have. Nursing homes are also in desperate need of reinforcement. Again, you're not seeing necessarily the amount of devastation that you saw in nursing homes last year, but you do have a lot of burnout. If staff get sick, they have to call out, and so you have a staffing shortage. And then, of course, if a resident tests positive, you have to cohort them. There's a lot more PPE use, a lot more federal regulations and testing that you have to go through. So the nursing homes are in need also of a lot more staff help. And so, you know, we are trying to work through what options there are to provide them with the support that they need. I think another thing that's coming out is that our capacity for isolation is a lot more limited. You know, Dr. Berraman talked about having a plan, right? Dr. Charles talked about having a plan similar to a natural disaster. Unfortunately, I think the isolation is much more limited. You don't have hotel rooms in the same way. You have less unencumbered funding. The CARES Act was really, you know, even though there were some limitations on the funds, if it was for COVID, there was a lot more money that you had to use by a certain date. And so there's a lot more money going into supporting certain projects. And unfortunately, the American Rescue Plan funds have been generally dedicated in state and county budgets. I mean, it's unfortunate in the sense that we're having this surge and could use more unencumbered funding, but it was also very important to balancing our budget. And Congress has generally moved on. They're not necessarily interested in doing much more in terms of COVID relief. They've really moved on to the infrastructure bills that they're looking at and the budget bills. In fact, some of the pay-fors that they're paying for the infrastructure policies are by taking some money out of COVID relief. So I think that's a concern, and it's a question of whether or not Congress might have any interest in potentially providing any more sort of unencumbered funding to help in this situation. And again, you know, as Dr. Biermann said, there is burnout among our healthcare workers. There is some compassion fatigue, although everyone is taking care of everyone who comes in. You know, there is a fatigue that comes along with being this far into a pandemic and experiencing this surge. There have been retirements that lead to some of the staffing shortages, and there's a public that's just ready to move on, similar to what Dr. Biermann discussed. So to the next slide. And so some of the proposals that we've heard for action, because I know this webinar talks about, you know, things that are being considered, vaccine mandates, of course, are being considered. We've seen that one of the largest employer in the state, right, the state government, the county governments have required it. That requirement went into effect this past Monday, although I think there's some sort of grace periods in terms of the testing and getting all the paperwork in. I'll note that HIH has taken a position that all healthcare providers should mandate a COVID-19 vaccine. It is mandated at HIH, and many of our members, including HBH, I know Dr. Ashton is next, have gone beyond that. They've required a COVID-19 vaccine before it is fully authorized, and they are working towards implementation and seeing that policy through. But that effort will, of course, take many weeks to bear fruit. We know that there was a limitation put on gathering sizes just last week. There were some exceptions for these professionally planned events. But I think that there's been a lot of discussion about, well, what might be next and what might the trigger be for that. So of course, we're talking about vaccine passes, whatever you want to call them, the passport. I know there's a lot of different sort of names around it. Further gathering restrictions. There's talk about how you could modify the safe travels programs, mask mandates outdoors, and then a curfew. And just to explain the curfew would be designed to try and avoid traumatic injuries in particular, to keep them out of the hospital. So trying to avoid people going into the hospital for non-COVID related issues. The major question I think that a lot of people have is, what are the triggers to start implementing those more strenuous restrictions? And not just now, but if we do have surges in the future. I know there's been a lot of discussion about, we'll think about it when the hospitals are at capacity, and we are at that point. So I think now is a question for our policymakers is, at what point do we, take some of these further actions and make potentially further restrictions or make certain changes to what's allowed, especially with the hospitals where they are. And we're getting the staff in that is going to help immensely, that is going to be a lot of relief. But I think it's a consideration if we have to bring in 550 staff, what policies we should be taking in the future. So with that, I'll hand it over to, or I'll stop there and I'll hand it back to you, Makamai. Thank you.
Great, thank you, Paige. Thank you for that. We will transition over to our last speaker, Dr. Melinda Ashton.
Okay, I hope you can see my screen. I was asked to talk about sort of the hospital experience, and I thought it would be worth talking a little bit about where we've come from, because a lot of what we've learned about managing COVID-19 is still highly relevant to the Delta variant of COVID-19. So I thought it would be useful to just sort of talk about from the beginning the sorts of things that we were interested in doing and learning about and so forth. So our main concern at the beginning and continuing is the need to protect our employees from infection, to of course take good care of our patients and protect them from getting infected when they're with us, and then helping to protect the community. So we spent a lot of time learning about how to do personal protective equipment, how to manage the supply, how to ensure that our staff were safe. We set up our own systems for contact tracing among healthcare workers and patients so that the Department of Health didn't have to take that on. And we've actually gotten very good at that. And we do, unfortunately, continue to see that our employees are having community-associated contacts or infections. And so we continue to need to contact trace those and ensure that we're not seeing spread. And honestly, we very rarely see any spread. We generally just do a whole lot of evaluating, testing, and then a sigh of relief when people are not in fact infected from contact. We had to spend a lot of time learning how to care for COVID-19 patients, brand new disease. And so we, a whole lot of information was being thrown at us early on, and actually continues to be. So we were evaluating what we were learning and trying to understand how best to set up the healthcare system to best manage. And so we set up drive-up testing because we didn't want these patients to be in clinics and offices getting testing done. And we continue to do drive-up testing. There's been an incredible increase in the need for that recently. We set up respiratory evaluation centers where patients who are suspected or known to have COVID can be seen in person safely. And again, relieve the burden of PPE management on the private offices. And we have done a whole lot of virtual care and continue to do that, and have found that that's both very effective and very popular. So that's something that will be sustained long after the pandemic is done. We have spent a lot of time educating the clinician community because there's such a deluge of information. Nobody can keep up with it. And so having it a centralized sort of repository where I and some of my very helpful colleagues pull the information together. And then we, for a long time, we're having weekly webinars that were attended by many, I think, including probably some of you, to try to help people understand the science, understand the operational changes or challenges, and to also gather feedback from folks about how they were doing, what questions they had, what did they need. And that's been very helpful. We also have had a bulletin that we put out essentially daily. For a little while we didn't have to, but just updating folks with what are the latest travel restrictions, what are we doing about testing, what's out there in the community that you have questions about. And that's been very helpful as well. And then we found midway through last year that there was a lot of misinformation about how to protect a workplace. And so people, well-intentioned employers were giving all kinds of bad advice to their employees or employees' families about what to do under certain circumstances. So we set up a hotline in order to help people know exactly how to respond. What was the appropriate amount of time to stay home? When did you test? Not today, maybe wait a few days, things like that, that I think was helpful as well. Of course, vaccinations, as soon as the vaccine became available, we dove right in. And I think it should be recognized that we and all the other healthcare entities in the state really are not experienced in doing vaccinations for large amounts of people. I mean, nobody really is. The Department of Health has some experience with the Stop Flu at School, but this is something that we all felt so strongly. The community needed us to step up and do what was needed. And that's what we have done and continue to do. So of course, our employees first, the affiliated medical staff members, and then expanding out to others in the community who were healthcare workers in Tier 1A. And then of course, all of the subsequent waves of vaccination. And so I'll just show you, a few pictures. I think many of you probably are fully aware that we had our mass vaccination site at Pier 2, which closed at the end of July. We did somewhere around 185,000 doses of vaccine at Pier 2, and that was its function. It was supposed to be a mass vaccination center. We knew that it wasn't getting into the community in some parts of the community that really needed the vaccine. As Dr. Biermann said, equity is a problem. Access is part of that problem. So then we came up with our Vax Bus, which has been extremely popular. We started this in early May, and this allows us to take a vaccination team and all of the supplies needed to various locations around the island here. We are fully booked for the vaccine bus, and we're getting great response. This is a picture of a setup for vaccination at one of the high schools, and pretty typical setup that we had. And the team comes, they set it up quickly, they get going, and they vaccinate hundreds of people. And Dr. Biermann talked about the game has changed. I'm not very sporty either, but I think what we felt in probably May and June was that, wow, this was a marathon. And you know what? We're near the end. We were so hopeful that vaccine would be the answer to the problem at hand. And we had just a very few short weeks where people were sort of smiling at each other and saying, hey, we've done a good job. This is great. And then I think the game changed. And the way I look at it, what we didn't know was we signed up for a triathlon, and now it's time to swim. And I'm sure that I'm getting the triathlon metaphor all wrong, but it feels like it's an entirely new, really difficult task ahead. So that's my sports analogy for you. So here, we're all showing graphs. They all show basically the same thing. I'm showing here just July and August to date for our inpatient COVID-19 activities. So the blue bars are inpatients with COVID infection. The orange bars are those inpatients with COVID infection in the ICU. And the gray line is our total number of ICU patients. So you can see as we got into August, we had a higher proportion of our ICU patients being COVID infected. they're not all of our ICU patients. And I think the point was well made that we're also seeing other patients who require a lot of care. And some of that is attributed to delay of care from the last time that we had a surge when we shut down a lot of essential activities. So that's a problem as well. Here's our vaccination activity. Again, just July and August. And you can see in the last few days, we've had a big bump up of the number of doses of vaccine being given. And that is largely because of the announcement of the availability of a third dose for those who are immunocompromised. The vaccines here are, the blue bars are Oahu, the orange are Kauai, and Kauai does not have a vaccine clinic at Wilcox every day, and so you'll see bars that vary. But you can see that there's much more interest in vaccine in the last week or so than there was earlier in July. We're very grateful that a very generous donor on Kauai gave 3 vans to allow mobile vaccination clinics. And here's a picture of the one that Wilcox Health manages. And they were allowed to use one of the vans for their use. So this also is the same idea as the vaccine bus, getting the vaccine sort of out to the community where perhaps we can access or get people vaccinated who wouldn't otherwise come into our centers. I know there's interest in how we're doing in the hospital, and I thought I would put this up. The age breakdown of COVID patients has definitely changed. In the past surges prior to vaccine, the vast majority of our patients were seniors. And you can see here that the vast majority of our patients now are not seniors. And that is consistent with what's being reported all around the country. So we are not any different here in Hawaii. I thought I would show you this slide. This is a new version of some data that I wanted to show you. Now, you might notice that on my previous slide for today, we had 66 cases, and this slide has 67. It's a very dynamic thing. So what happened between the 2 slides being made was one more patient was admitted to the hospital. So this is to make the point that vaccination is protective. There are not many patients in our hospital that are fully vaccinated, and the vast majority of those are 70 or older with other health conditions that add to their risk of having severe enough disease with COVID to end up in the hospital. So moving forward, as was already mentioned by Paige, we have mandated vaccines for our HPH employees and for anyone else who comes into our facilities to provide any kind of service. That will be effective October 1st with the requirement that people be fully vaccinated, which means that the last dose of vaccine must be given on September 16th. There is an allowance for medical and religious exemptions, as is required by law. We are absolutely continuing to promote and provide the vaccinations in the community, actively doing third doses right now. We're preparing for the boosters that were just announced in the last day or two, and we're very much looking forward to vaccinating kids under 12. And then I think it's important to say that, yes, our staff are tired. They are absolutely rising to the occasion. There is no question that we will provide the care that is needed, but we're looking forward to that relief staff that's coming in next week and then after that. That will be very helpful to us. But at this point, we are doing well. Our staff are amazing, and so far, so good. So I think I'll end with that. Thank you.
Great, thank you, everyone. Those are some great presentations. We have time for question and answers. We've got a lot of questions, and I wanted to ask the speakers if I could have maybe like 5 extra minutes on the webinar for you folks, if it was okay if we ran just a little bit over to get through some questions. So, okay, I appreciate that. First question we have for Dr. Ashton: is there any data indicating longer term impacts of the virus on those vaccinated who then contract it? Does being vaccinated help protect against the long-term impacts of contracting the diseases?
I think it's a little bit early yet to actually know whether people who have breakthrough infections, so those who are fully vaccinated but have an infection, whether they're going to suffer from long COVID or not. We know that long COVID is a real concern for many who have a COVID infection. And what that means is that the effects of the virus last longer than we would expect. So many people, most people recover by 6 weeks or so, but the long COVID folks can go for many weeks or months after that. Interestingly, folks who had long COVID from the original wave of COVID infections, some of them actually had resolution of their long COVID by being vaccinated. So it's a new game. We don't really have all of the answers yet. So it is very clear, though, that unvaccinated folks that have COVID can certainly suffer from long COVID. And some of them were not very sick or might even have been asymptomatic. And so it's an interesting problem.
Great, thank you. Paige, do we know how many hospitalizations are tourists? Do you folks have a count on that?
I have not seen any data where we're able to parse out who is tourist and who is a resident. I think that in the past we've asked about that, but I'm not sure that that's a particularly practical data point for our hospitals to provide on a daily basis.
Thank you. This question is for anyone. When we see the increased number of positive tests, who is being tested? Are these all people who are symptomatic or routinely being tested? Are they visitors? Sorry, that's kind of like a question. Are they visitors, and do we know where those numbers are coming from?
I can take a first pass at that. You know, one of the things that the health department and our partners have done in recent weeks is really ramp up the availability of free community testing. And those sites are targeted not at people who are acutely ill and symptomatic, but people who are being tested because they're concerned, because they think they may have been exposed, because they've traveled recently, because their employer requires it before they go back to work. So to the extent that free community testing has made testing more available, I think we have better eyes on what's going on community-wide than when we're only testing people who are symptomatic through the healthcare system. But we don't have demographic information on everyone tested. Things like, are you a resident? Did you travel recently? Are you a visitor? We only gather that information through the case investigation when people test positive.
So I would just add that, you know, the person asking the question gave a whole list of different people that might be being tested. I think the answer is yes, all of them. So it's people who are ill and worried. It's people who are exposed and worried. It's people who are worried for no particular reason other than they are worried. And then there are others who are being screened for work or other reasons.
Great, thank you for that. This question is for Dr. Biermann. Does the state have adequate supply to provide booster shots for Moderna and Pfizer and simultaneously continue new vaccinations?
I believe we do. Dr. Ashton may have better eyes on that than I do, but my sense, the state actually has not needed to order any more federal supply of vaccines until recently. As we see demand pick up with the third doses and potentially booster doses and people being more concerned, I certainly anticipate that we will order more, but I'm not aware of any supply issues.
Yeah, and we have not yet experienced any either. We're, it appears that there's plenty of vaccine.
Great, thank you.
And if it's okay, I'll sort of add to that if it's all right, that, you know, just to echo what Drs. Biermann and Ashton said, it doesn't appear that we have any shortage. I've seen reports that I think the administration believes it has enough supply on hand. You know, and then we're looking though at also engaging pharmacy partners again, you know, to do booster shots in our long-term care homes. So, you know, one of the good things is, you know, we've been doing this for a few months. And so I think some of maybe the kinks at the beginning have gotten a little bit more worked out. And so hopefully the distribution won't necessarily be such a bottleneck as we look towards having boosters.
This is kind of a follow-up. Is it okay to take the COVID booster and the flu shot at the same time this year? Would you?
I have not seen data specifically about that, but I believe that the recommendations are that the vaccine can be simultaneously administered with any other vaccine. So I would say yes.
We have a question. This is for anyone. I can to all three of you. What restrictions would have the biggest impact on curbing our numbers? And if you have an idea of how soon they should be implemented? Anyone, yeah.
Janet, why don't you take that one? I think that's a public health one.
Oh, here, I thought you were volunteering to answer that one, Melinda. Well, of course, the restrictions that get put in place ultimately get put in place by our elected officials. Those are policy calls. And they are done with advice and recommendation from the health department, but also with considerations outside of the health department. So from business and the rest of the community. And, you know, anything that minimizes exposure to other people who can spread disease is going to reduce the spread of disease. So whether we decide to have a full-on stay-at-home order or to limit gatherings even further or to require masks everywhere, you know, all of these things, any one of those things would have that effect. So I think we really have to think, though, about the decision is based on not just disease spread, but also what's the impact on all of the other things going on in our state and our economy that we know have an impact on health as well, on mental health, on food security, housing security, all of that. So right now, we are taking the approach of doing all of these things that were in Dr. Char's talk and my last slide, in addition to having vaccination and, you know, gambling that that's going to be enough to keep our healthcare system intact, able to care for those of us who get sick and prevent the loss of life. But the game isn't over, and we don't know whether or not that will be enough. And you know, whether how risk averse we are and whether we're willing to continue on this path and how far we let it play out, I think is a decision that all of us will be making together.
Yeah, and I would add a couple of things. I think we've learned a lot from our experience with the pandemic to date, and we know what the risk benefits are in terms of shutting down schools, you know, shutting down the state so that none of us go to work and those sorts of things. So I think we're more informed in terms of what the effects of all of those things are. The problem is really this unknown about how bad is it going to get, right? It's all looking pretty scary right now. There is one set of modeling that says it's all going to stop circulating here pretty fast in the next week or two, you know, very abruptly fall off the cliff. That could happen. I don't think anybody knows, and that it's the uncertainty that's so difficult.
This question is for you, Dr. Ashton. Does the mobile vaccination buses administer the Johnson & Johnson vaccine, or is it just the Moderna and the Pfizer vaccines?
We carry all three types of vaccine on the bus.
Okay. Another question, does anyone have any idea when rollout for vaccines for those under age 12 will happen?
Reading the tea leaves, it could happen at the same time as the booster announcement, honestly, and that could be very difficult for us in terms of, you know, access, but the timing seems to be about the same. So September-ish is what we're hearing, I believe. Janet, do you have anything different about that?
I know that there was a call earlier, a national call earlier this week at which people were actually anticipating that it might be a little bit later than that. I think related to the FDA's request for additional study size. So the most pessimistic were sort of November, although there were still some optimists looking at September.
Yeah, and I think the additional data was mostly Moderna.
Great, thank you. Paige, we have a question for you. What supports are available for our healthcare workers who are dealing with burnout, fatigue, and stress?
Sure, and you know, I will turn this over after I respond, I think, to Dr. Ashton, who I think probably would want to speak to what they're doing at HPH. I know that that's a big question that we're hearing from a lot of our facilities. There are a number of federal resources. So I know the American Hospital Association in particular has provided a lot of guidance to hospitals about ways to manage the mental health of their staff, to provide sort of best practices about ways to address burnout. I think like many things in healthcare, we can kind of go from those best practices, and each facility can decide how to best tailor that to their staff. I think every single hospital I've talked to has been interested in trying to provide that type of support to their staff. I will say that I think, I appreciate that question in the sense that I think it does recognize how much of a burden I think this next stage of the pandemic has been on a lot of our healthcare providers. And I wanted to say it's not just hospitals, right? It's also nursing homes, it's hospice, it's home health, it's people in community health centers, in urgent care clinics, in your physician office. And I think a lot of what we're hearing is not just that we're tired, we're burnt out, when we need help, but it's really a plea for the community. And I think that's something that we've been hearing a lot from our members in particular, is a plea to the community. And I think you're seeing increasingly from a lot of our providers to please get vaccinated and to please try and do what is right to protect the community. I think that's sort of where I'm seeing more of the frustration these days, is that you have people going in and day out and seeing potentially avoidable cases. So I think that, I'll just make that plug, that another plug, probably everyone on this call has already bought in. But, if you can have someone who might be hesitant, talk to a physician, talk to a trusted friend or family member who is a provider to share that experience. I think that could be very powerful, because I do think that's a lot of what we're hearing from our providers. But I would be interested to know, if Dr. Ashton or even Dr. Biermann, if you're hearing from providers, what kinds of things they're doing to address that particular issue in question.
Yeah, so I'll comment. First of all, I think we could acknowledge that we had a burnout problem among physicians well before the pandemic. So this is not new, it's just worse. And the reason I used that triathlon kind of idea was, I think there was a real feeling of relief for a very short period of time. And then there is such a burden now on folks, because we don't need to be here. We are here, but we shouldn't have to be here. And I think that adds an additional layer of despair, perhaps. The other piece that I think is really weighing on folks, I was out at the vaccine clinic at Waipahu High School when Dr. Biden came to visit, and the protesters outside were so loud and so obnoxious. And I was just watching the effect on the folks working the vaccine clinic. And it's really hard when you're in there, on a Sunday, trying to do your best and get people vaccinated, and having others outside, sort of loudly declaring how awful you are. That's tough, right? So I think it's burnout plus. It's the circumstances we find ourselves in, with all of the misinformation out there, that we just don't know how to cope with, honestly, how to fix. And in healthcare, we often really like fixing things. And so I think when we came through the initial part of the pandemic, and we had done well, and as HPH, we felt good about how things had gone, and we were vaccinating people like crazy. That was a very big mood enhancer. And now we are not there. And I think that's the difficult part. As far as what we're doing at HPH, an awful lot of conversations about how are you doing and what can we do to help, and trying to make sure that people are talking to each other, that leaders are checking in on folks. It's that, I care about you kind of message, I think, that is most important. And honestly, burnout is such a personal thing to deal with, that we need to make sure that we give people space for that. But I think that we're dealing with just this different flavor right now, which is really hard for folks.
If I could comment on the public health side, because often public health doesn't get included under the umbrella of healthcare worker. And similar to what Dr. Ashton described, you've heard statewide data that we're only reaching about half of our cases to do an initial interview with them. And lots of those are people for whom we do have a phone number, but who hang up on us, or tell us that they aren't interested in talking to us, or don't answer the phone. And on Kauai, we've been fortunate. We are reaching many more than that. But even so, as we monitor people, as we talk to them, as we interview contacts, I'm hearing increasingly reports from my staff of how abusive and unpleasant and just nasty, frankly, people are in the community. And I think that reflects the fatigue that's community-wide. And that's essentially burnout in our residents, as well as burnout on the worker side. But it contributes to that, to the difficulty of doing the swim, which I think actually comes before the marathon. But
Well,
anyway.
yeah, I figured that out too, but whatever.
I love the analogy.
I told you I didn't know anything about it.
That's so funny. Well, thank you all. We're kind of wrapping up, and I know we have a lot of questions left over. So to the participants that had asked questions, we are gathering them. Our HIPHI staff is gathering them, and we will do our best to have our speakers answer them and distribute those answers to you folks in our Mahalo email. So just wanted to wrap up and say thank you to our speakers, Dr. Berraman, Dr. Ashton, and Paige for being our guests today. Thank you all for joining us on Zoom. And lastly, to thank all of our HIPHI staff behind the scenes. We will please save the date for September 1st for our next public health action webinar, and we will share those registration details as we get closer to the event. But again, please everyone be safe and be well, and we will share this recording following this presentation. And much mahalo to our guest speakers for joining us today. Aloha, everyone.
Thank you so much.